Hi everybody, it's Lana Comstock. Welcome to the Falls Prevention Community of Practice. Today's October 17th already. It just seems pretty amazing that we're just jumping right through fall and all the hoops and things to follow here. I'm pretty excited about today's presentation, but we're going to do the few housekeeping pieces that we normally do. First of all, I'm going to go ahead and mute everybody. And now I'm going to go through and make sure that we have our presenters unmuted. I have a note here from Nancy that she doesn't have any audio and has how we gotten started. So I just want to make sure that you can all hear me. As we move forward with our slides, the first thing is kind of our housekeeping tips. We want to make sure that you are muted. You can unmute yourself if you want to chime in or ask any questions. We have the chat box, and we do encourage that you utilize that. And so as we move forward here, I'm not seeing any further concerns about audio, so we're going to go ahead and get started with our presentation. I want to do just a brief introduction, and today we have Dr. Patricia Dykes. She is a senior nurse, scientist, and program director for nursing research at Brigham and Women's Hospital Center for Patient Safety Research and Practice. Now, Dr. Dykes is an associate professor of medicine at Harvard Medical School. Her expertise includes medical informatics, patient safety, and clinical decision support. Dr. Dykes and her team have developed a decision support and communication intervention for use by their care team, patients, and family members to prevent patient falls that reduced in-hospital falls by 25% in a randomized controlled trial. She is conducting research on the bedside data needs and preferences of hospitalized patients and evaluating the use of patient-centered technology for patient engagement in their plan of care, as well as adverse event prevention. We also have Megan Duckworth, and she is the primary research assistant working on fall prevention in Brigham and Women's Hospital Center for Patient Safety Research and Practice. Megan's areas of expertise include patient safety, patient engagement, and implementation tools and strategies to sustain an evidence-based fall prevention program. We want to welcome you and want to thank you also for joining us. And I will advance this slide and turn the webinar over to you. Give me one moment to make sure I have you unmuted. You want to try to speak again?
Sure. Good afternoon, everyone. This is Patricia Dykes, and sitting with me here is Megan Duckworth at Brigham and Women's Hospital. Can you hear me?
We certainly can. Thank you so much.
Okay, great. So we're thrilled to have this opportunity to present some of the work that we're doing here in other hospitals across the U.S. on fall prevention, specifically conducting research to evidence-based nursing care. Are you going to be changing the slides, or do I have the ability to do that?
I'll just change the slides, so if you need me to advance, if I'm not doing that timely, you can just let me know.
Okay, so fall tips. So we're going to be talking about the fall tips patient education and clinical decision support tool, and we do share it without charge, but it can't be altered without written permission from Brigham and Women's Hospital. When I talk about the research we've done over the next couple of minutes, you'll see that every piece of the tool is based in research. So we're going to talk very briefly about the extent of the problem of patient falls. Then we'll discuss the components of an evidence-based fall prevention program, and we'll use fall tips as a model. And then we'll talk about some of the strategies, tools, and tactics for integrating and sustaining fall prevention research into practice. So I think if you're on this webinar, you're probably very familiar with the problem of patient falls. Falls are a leading cause of death and disability. About a third of older adults fall every year. We know that hospitalization increases the risk for falls. About 3% of hospitalized patients fall, and about a third of those who fall actually also sustain an injury. Patient falls and injury falls are employed as national metrics for nursing quality care. And as of 2008, the costs related to fall-related injury are no longer reimbursable, by Medicare and hospitals. So before we began our fall prevention research here at Brigham and Women's Hospital and Partners Healthcare, there was some evidence related to fall prevention. There had been research conducted in looking at why patients fall in hospitals. There were many risk assessment tools that were already established, and some of those were validated. So we knew, what the risk factors were that placed patients at risk for falling. What we didn't have were an evidence-based protocol that linked the risk assessment with interventions that we could do to prevent a fall. We did have paper-based fall prevention guidelines. They were consensus-based. Those interventions were not tested in the clinical trial, but they were developed by experts agreeing that these interventions were likely to be effective. And so if you go to the next slide, this is a summary of the randomized control trials that had been done before we did our study. One was related to bed alarms, and then the others were targeted multifactorial intervention studies. And none of these studies were a positive trial. They didn't show a significant reduction in falls in the hospital. And so in 2007, we were funded by the Robert Wood Johnson Foundation to create a linkage between the fall risk assessment that's done by nurses in, very likely, when patients come into the hospital, and at least once a day in most hospitals across the U.S., an intervention to reduce falls. So specifically, we wanted to find out, what is the intervention protocol that will decrease falls in hospitals. We used two phases to our approach. We started with a qualitative phase, asking nurses, nursing assistants, patients who had fallen in the hospital, and other professional providers why they thought that patients were falling and what interventions they believed were both effective and feasible in hospital settings. And then from that, we created a fall prevention toolkit that we called Fall Tips. And then we conducted a randomized control trial to test the Fall Tips intervention across the 4 hospitals in Boston. And so from our qualitative work, we came up with a set of requirements. At a very high level, we found that patient falls in hospitals are a communication problem, that nurses are routinely doing fall risk assessments, but the degree to which they communicate the results of that assessment and their fall prevention plan to other members of the nursing team, to their professional and other professional providers, to patients, was highly variable. And so some of the requirements that we had, can you go back, please? Previous slide, please. And so some of the requirements were first that we needed to leverage existing workflows, that nurses were routinely doing fall risk assessment, and they were hanging high risk for fall signs at the patient's bedside. But what we learned from our work with nurses is that these signs were really quite ineffective because high risk doesn't tell you, why the patient's at risk or what you need to do to prevent a fall. We also found that the intervention needed to support teamwork, that nurses work within a team. Very often they might be in with a patient doing complex treatments or interventions. They relied on other members of the team to answer call lights. And when they did that, they needed to, their team members needed to know why, for each patient, what their care plan, what their fall prevention plan was. And that fall prevention plan needed to be tailored or individualized to each patient, because patients who are at risk because they have a cognitive disturbance require different interventions than patients with a gait disturbance. And so if you answer a call light, you need to know exactly how to help that patient. We also learned that tools to we also learned that surveillance, tools to support surveillance were important. That as we walk down the hall, as we redo our hospital units, we're tending to move from 4-bedded rooms to single-bedded rooms. And in the old days when we had multiple bedrooms, if a patient started to get up, sometimes their roommate would put the call light on and let us know, but that's not true anymore. So we need to have information in the workflow so anyone walking down the hall, if they see a patient get up and it's appropriate for them to get up, we can encourage that. But if they need help, we need to know how to help them. Okay, next slide. Next slide, please. Thank you. And so we developed this Fall Tips Toolkit, and this is a screenshot from our EHR. On the left-hand side is the Morse Fall Scale, which really provides a foundation for doing the fall risk assessment. And then on the right side are the interventions that we had learned in our focus groups and our qualitative work that were both effective and feasible in an acute care hospital. And the way this worked is that the nurse would do the risk assessment, and as each area of risk was checked off, the clinical decision support in the background automatically linked the area of risk to the intervention that was likely to prevent a fall. Once they completed the assessment, they reviewed it. If they needed to add additional interventions based on their clinical judgment, they could do that. But once they saved it, a couple different tools printed at the printer near the computer. If you could go to the next slide. Keep going, click through. One more time. Okay, so this is a picture of one of the tools, was a fall prevention poster. And so this could have anywhere from 0 to 6 icons. It was completely dependent on the clinical documentation in the electronic record. And so for this patient, you can see that if you answer a call light on this patient, we see that she has a history of falls. We know that she's much more likely to fall again and under similar circumstances. We also know that if this patient has to go to the bathroom, that I can get this patient up myself because they're out of bed assist with one person, that they need their walking aid to their walker to walk safely. I also see that there's a bed or chair alarm icon, which tells me that either the patient's confused or they don't reliably call for help. So if I do help them to the bathroom, I need to stay with them until they're finished. Next slide. We also printed out a one-page patient handout, which was tailored to include a patient-level health literacy description of why this patient's at risk and what risk factors and what kinds of interventions we're doing in the hospital to prevent them from falling and how they can partner with us. We learned from our work with patients that they don't like generic fall prevention materials, that they want to know really only how this pertains to them. Next. And so we did a 6-month study where we studied this in 4 different hospitals in the Boston area and over 10,000 patients. And we found that falls were reduced by 25% on the intervention units. We found that the Fall Tips Toolkit was most effective with patients aged 65 or older. We didn't note any difference in fall-related injuries, but we weren't powered for that outcome. We did publish our results in the Journal of the American Medical Association. Next slide. And so coming out of this work, we learned some important lessons. And one was that fall prevention in hospitals is a 3-step process. We need to conduct fall risk assessment using a prospectively valid and reliable tool. We need to use the results of that assessment to develop a care plan that's tailored to patient-specific areas of risk. And then we need to make sure that we implement the plan consistently. And strategies and tools that facilitate this 3-step fall prevention process should prevent patients from falling. Next slide. And so coming out of the original Fall Tips study, our next steps were first to identify ways to disseminate fall tips broadly and outside of the electronic health record. So we got a lot of queries from hospitals that either didn't have electronic health records or didn't have staff who could build fall tips within their EHR. And so we took it on to try to develop tools that could be used in those hospitals that would translate the fall tips evidence. We also did a case control study looking at why was it that some patients who were on the intervention unit in our original study still fell. And what we found was those patients were mostly younger, and the most common reason why they fell was because the patient didn't follow the plan. And so we hypothesized coming out of this that if we partnered more with the patient from the very beginning, meaning that instead of having the nurse do the risk assessment, having the nurse develop the plan, and then teaching the patient about it, if the nurse did the risk assessment with the patient, then they would be more likely to understand and hopefully believe that they were at risk. And then if they developed the plan with the patient, then the patient would, hopefully be more invested in helping us make sure the plan was implemented consistently. And so our next step after this study was to try to develop tools and strategies so that we can engage patients and families in all three steps of the fall prevention process. Next slide. And so this is a laminated paper fall tip. So we developed this in conjunction with the systems engineering group at Northeastern University. And so here you can see on the left-hand side this is the Morse fall scale that we translated into a patient level of health literacy. And then on the right-hand side are the interventions that we used in our randomized control trial. And we use color to link the areas of risk to the evidence-based intervention, so to provide clinical decision support, in other words. So, for example, if a patient has secondary diagnosis, if you look at Dr. Morse's work, she says that, not only are we looking at the multiple medical diagnoses and associated symptoms, we're also looking at the long list of medications that those patients tend to be on and some of the side effects. And one of the things we'd be thinking about is, based on those medications and their symptoms and side effects, does this patient need a toileting schedule? Do they need assistance to the bathroom? So using that to really help us to create a tailored plan. So if you go to the next slide. We created this tool in both English and Spanish. Our partner institution with developing this work was Montefiore Medical Center in the Bronx. 60% of their patients are Spanish first language, and so we wanted to create a tool that could be used with more than just with all types of patients, any language. And so we did a 6-month study where we looked at medical and surgical units, neuro units, and oncology units that their fall rate was above the mean for the state. We did this both here at Brigham and also at Montefiore Medical Center. We looked at not only what the fall and injury rates were, but we looked at actual completion of the fall tips protocol. And we found that the protocol adherence was quite high over that 6-month period, about 82%. And we saw a reduction in the fall rate from 3.28 to 2.8, and our fall related injury rate was reduced in half. Next slide. At Montefiore Medical Center, they also had a good adherence with the fall tips protocol, probably better even than we did here at Brigham and Women's Hospital. Their fall rate started out fairly low, 3.04, and it was 3.1 during the intervention phase, but the injury rate was reduced from 0.47 to 0.31. And so this work we recently published in the Joint Commission Journal on Quality of Safety. I believe it's the August issue. Next slide. And so what Fall Tips does is it provides us a tool for providing personalized fall prevention assessment planning and patient education and engages patients in the three-step fall prevention process. Next slide. So when we started the webinar, I talked a little bit about the evidence that was in place related to fall prevention in 2007. And so here we are a decade later, and the evidence that's in place now includes that patient falls are a common problem and that they can be prevented using the three-step fall prevention process. There are tools available for use in clinical care to integrate the three-step fall prevention process into the workflow, and fall tips is one way to do that. And that we also know that engaging patients and family in the three-step fall prevention process ensures that they understand their risk factors and that they can play a role in ensuring that the fall prevention plan is implemented consistently. So that concludes the first part of our presentation, which was just to try to give you some background into the science behind fall tips. Now we're going to talk about the components of an evidence-based fall prevention program and flesh that out a little bit. Next slide. And so the components of an evidence-based fall prevention program are that we need to have standard definitions. We need to be defining falls and fall-related injuries the same. We need to provide universal fall precautions for every patient. And then we need to conduct the three-step fall prevention process. So that's the fall risk assessment using the validated tool, tailored fall prevention care planning, and then we need to consistently implement the plan. We need a post-fall management strategy. And then we need to really think about implementation and sustainment. And so we're going to be, Megan's going to be talking about some of the strategies that we have for sustaining an evidence-based fall prevention program. Next slide. You need to click ahead. So the first, the evidence-based fall prevention strategies that we have are universal fall precautions that apply to all patients, and the three-step fall prevention process and post-fall management. And we'll go through each of these. Okay, so we're going to be focusing, actually, can you go to the previous slide? Sorry about that. Okay, so we're going to focus in on the three-step fall prevention process, which, as I mentioned, is conducting the fall risk assessment, completing a tailored plan, and then consistently implementing the plan. So starting with step one, the fall risk assessment. Next slide. So, we need to do a fall risk assessment because this is how we identify patients who are at risk for anticipated physiological fall. It also provides a baseline measure of the patient-specific areas of risk. It helps us in our clinical decision-making, and then it will inform a tailored or personalized preventive measures, care plans, and communication strategies. So standardized fall risk assessment is really a prerequisite to implementing an evidence-based fall prevention intervention program. Next slide. Now, I know that there are many fall risk assessment tools out there in the literature, and what's important to look at is, has the tool, for any tool that you're going to use in clinical practices, has it been prospectively validated in more than one population so that we know its accuracy will work with different types of patients? What are the sensitivity and specificity analyses or the accuracy of the tool over time? Does it have good face validity? Can you tell by looking at it, the different items, what they mean? Does it have good inter-rater reliability? So if I use the tool on a patient and Megan uses it on the same patient, are we going to come up with the same assessment areas of risk and score? And there should be a transparent, simple calculation of score. Next slide. So here, across Partners Healthcare, we use the Morse fall scale. The Morse fall scale predicts the likelihood of a patient falling. It's transparent, has a transparent, simple calculation score that can be completed in less than 3 minutes. It was developed using rigorous methods by Dr. Janice Morse in the 1980s and tested over time. The sensitivity and specificity are decent for this tool. Next slide. There there are some common misconceptions about the Morse fall scale. And so just to kind of talk about what the requirements are, with the Morse fall scale, you really need, it does require chart review and direct observation and conversation with the patient. You can't complete the Morse fall scale by just doing a chart review or by reviewing what the nurse on the previous shift documented. The Morse fall scale should be completed at least once a shift in acute care hospitals, only because in acute care setting, patient status can change rapidly, and so we need to weigh a way of making sure that if there's a change of status that we're assessing fall risk. And so the scores may fluctuate from daytime to nighttime. Completion of the Morse fall scale requires training, and so I would say one of the limitations of the Morse fall scale is the face validity. So if you look at the items, just the labels of the items, you wouldn't automatically know what each of these items means. It does require training. And it also requires competency because, you know, if the Morse fall scale is going to be used as the basis for the assessment and for the plan, then you have to make sure it's accurate. There are many limitations of fall risk assessment tools and scores. So we know that no tool has perfect predictability, that even patients at low risk require some level of intervention. So for example, if you base a patient's individualized care plan on their fall risk score alone, their care plan will not be tailored to the risk factors. We found in our research that even patients who are at low risk for falls still fall. So, you know, if a patient has one risk factor or 6 risk factors, you really need to look at not what the score is, but more focus on what areas of risk are present, and then make sure that you have an intervention to address each area of risk. Next slide. So, just to summarize the strategies for using risk assessment tools, you know, choose a valid and reliable tool. Make sure you train all staff in proper use of the risk assessment tools. All patients should be assessed. And then the intervention should be tailored based on the patient's specific areas of risk. And we all know that patients who fall once are likely to fall again and under similar circumstances. So when you're asking, always ask about previous falls, and make sure that interventions to reduce those types of falls are integrated into their plan of care. Next slide. Okay, so this is the Morse fall scale. The areas of risk that are present on this scale are history of falling, secondary diagnosis, ambulatory aid, IV therapy, heparin lock, gait, and mental status. And so Megan is going to be talking. Oh, okay, okay. Next slide.
The next step is completing the tailored fall prevention care planning. So those Morse fall scale areas of risk, if you remember back to the fall tips laminated poster, those map to the patient level of health literacy risks that are shown there. So when you're completing step 1, you're looking at the Morse fall scale risk factors, but those map over to what is included on the fall tips tool and what you share with the patient. So in step 2, after you've assessed for those risk factors, you're reviewing those for each specific patient to create an evidence-based tailored plan for the patient. So you'll select the interventions to address each area of risk, and then make sure to communicate this tailored fall prevention plan to all staff, because through our research, it's been reinforced that fall prevention requires a team-based interdisciplinary approach. So all staff who interact with the patient should be able to see the tailored interventions to prevent a fall applied to each area of risk identified by the Morse fall scale. And then the last step moving forward is making sure to share it with patients and their family members. So in the next slide, the third step of the 3-step fall prevention process is consistently implementing the plan. It's making sure that you're carrying out the plan and reminding patients daily to help prevent falls. And patient engagement really is the key here. We conducted a case control study after the randomized controlled trial in 2010 and discovered that the reason that patients who fell on the intervention unit, so they did have access to the toolkit, but they fell, and the reason why in most cases was because the patient hypothesized since that patient engagement throughout the 3 steps of the plan will increase patient belief in that being in an unfamiliar setting with the introduction of new risk factors in the hospital setting can put a patient who's normally totally independent and can help themselves at home at risk. So step 3, consistently implementing the plan requires patient engagement. It ensures that they understand the risk factors and can play a role in making sure that the fall prevention plan is implemented consistently. They can also provide you information as you're tailoring the plan to the number of people that they think they need help with out of the bed. And then you're conducting the fall risk assessment with the patient and developing the tailored plan together based on those risk factors. And the workflow around the Fall Tips laminated tool is that it's completed at least once daily. And if nothing has changed in the patient's risk factors or tailored plan, there's still the workflow of reinforcing the plan with the patient. So making sure that they don't forget about the introduction of new risk factors that they might have while they're in the hospital. The next slide, please. And Patty's going to run through a case study here. So I know we don't have a way of interacting with everyone, but she'll walk through strategies of how to think about the different risk factors that a patient may present with, and then show how to complete the Fall Tips tool with the patient. Next slide, please.
Okay, so we'll start with our case study. We have John here as an 82-year-old man. He has diabetes. He was admitted to one of our medical units with chest pain and shortness of breath. On admission, he was found to be alert and oriented. He has an IV. He was placed on a cardiac monitor. During the admission interview, the patient reported that with his cane, he was independent with walking and transfers. However, the nurse noted that the doctor's order was for walking with cane and assistance only. With further questioning, the patient reported that he had fallen at home several times over the past year, most recently last month. As the nurse assisted the patient to the bathroom, she noted that initially John used his bedside table and other furniture as a guide. He needed to be reminded to use his cane. But once he was given his cane, the patient walked with short, steady steps to the bathroom. Okay, next slide. All right, so here is the laminated poster version of the Fall Tips Toolkit. And as I mentioned earlier, we have the areas of risk on the left-hand side and the interventions on the right that come from our research. And so the first area of risk on top is increased harm if you fall. And so here at Brigham and Women's Hospital, the nurses do what we call the ABCS of harm. It's an IHI assessment that looks at likelihood of injury if a patient falls. So A being for age, so patients who are 85 or older. B for bones, like do they have osteoporosis. C for coagulation, are they on anticoagulants where they could bleed out if they fall. And S if they've had recent surgery. And so if a patient, we've found through our research that if a patient is at increased risk for harm if they fall, if you tell them that, that they're more likely to follow the plan. And so, you know, we do our ABCS assessment, and if the patient is at increased risk for harm if they fall, we would check that box. Now, in this particular case study, John is not at increased risk for harm if he falls, based on what we know from the case study. In terms of the fall risks, we know that John has a history of falls, and so we would check that first box. And under the interventions, we would circulate, communicate recent fall and risk of harm. And so in our, while we're sitting at the bedside with the patient, we'd be asking John about that previous fall. And based on what he tells us, we would be adding interventions to the plan. So for example, if John tells us that, you know, he fell recently at home, he got up suddenly at night and got dizzy and fell. So then we would know that probably John should get assistance, you know, out of bed. Maybe he needs a toileting schedule. So that would influence how we mock up our plan. The second area of risk on the Morse fall scale is secondary diagnosis, but we know that also includes medications. So we'd be thinking through what are the symptoms that the patient has, what medications are they on, and what does that mean for their fall prevention plan. And so The yellow also guide you over to thinking about a toileting schedule, thinking about whether the patient needs assistance with toileting. If when questioning, if looking at the medication side effects, we saw that the patient was dizzy, then you know, that certainly would also point to the need for assistance with toileting. The third area of risk is walking aids. So we know that this, for John, he has a cane ordered and he has a cane at the bedside. So we would check off walking aid and we would circle the cane. But we would also reinforce with John how important it is to not use the furniture as a walking aid in the hospital, because it all happens to be on wheels and it's very dangerous. And so that will become part of our teaching plan. Under IV, we know that John does have an IV, so we would circle assistance with the IV. So here's another area where we would be thinking through, not only does the patient need help with the equipment, but what's going in that IV? Is this patient getting a lot of fluids, in which case they need a toileting schedule, they need assistance to the bathroom, what medications are going into that IV, and then based on that, selecting additional interventions, you know, using your clinical judgment. The next area of risk is unsteady gait or unsteady walk. And so we did see that John does have a little bit of an unsteady walk. And here is where we consider whether how much assistance the patient needs to get out of bed. And so for this particular patient, I think probably one person assist is probably fine, because with his cane, once he gets going, he seems to be okay. And then the last area of risk is mental status. So, you know, it sounds like John is alert and oriented, but he overestimates his abilities. So these are the types of patients that we would use a bed alarm on, because, you know, we don't know that they're going to reliably call for help, and they are at risk for falling if they get up on their own. If you go to the next slide. Okay, so this shows the Morse, it shows the fall tips toolkit completely mocked up. So here you can see that this patient, John, does have all these different risk factors, and the corresponding interventions are circled. This tool is 11 by 17. It's laminated. It's at the patient's bedside. The workflow is the nurse fills it out on admission, and then each day, if anything changes, they update it, review it with the patient, and change the date. So anyone who walks in the room knows that it's current, and it's also used as a teaching tool on a daily basis, reminding the patient about their risks and what the plan is to prevent them from falling while they're in the hospital. Next slide.
So now I'm going to start talking a little bit about implementation strategies. So these are the strategies that guided our rollout of the pilot here at Brigham and Women's Hospital, as well as at Montefiore Medical Center and at some of our other collaborating institutions outside of our first pilot. So the next slide, please. This was all guided by the Institute for Healthcare Improvements Framework for Spread. So this model helps participants consider the implementation requirements, develop a communication plan, and then design strategies to promote adoption by staff, as well as it includes strategies for sustainment. So the first component is setting up the expectation for change. And really this hinges on leadership support. So making sure that there's leadership buy-in that will then flow down towards staff engagement, and then from staff engagement, there's patient engagement. So I can't emphasize enough how important it is for leadership to express their support and express the expectation for change in the fall prevention protocol. As well as leadership, there should be the establishment of a fall prevention committee. And then with the CMS non-payment rule in 2008, there's the financial expectation for change in fall prevention practices. The next component is involvement of peer champions. The next component is involvement of peer champions. So if you don't already use the champion model, attending meetings with the practice committees and identifying champions that way, who will serve as the unit-based leaders, modeling the best practices for this implementation, providing just-in-time training, as well as being there for train the trainer sessions so that they can then go back and provide in services for the rest of their unit. The peer champion plays a huge role in sustainment as well, because they are part of the auditing process, which we'll talk about in a moment. And I can't emphasize enough how important their modeling of the best practices is. As a research assistant, I can say that having the support and the buy-in of champions on the units had 10 times more weight than my role as a research assistant in helping this implementation process. And then lastly, the third key component is continuous monitoring and feedback. So you can't improve what you can't measure. And so making sure that you are monitoring both the process and the outcome metrics, and then feeding it back to your staff so that they are aware that their efforts are making change, and that it's all not for nothing, and that the workflow and change and improvement will be sustained. It's not just a pilot, and it's there to stay. The next slide, please. So as a part of the implementation strategy, like Patty mentioned, there has to be standardization. So there's got to be a fall prevention, or excuse me, a fall and a fall with injury definition that is standardized across the institution. And then the metrics need to be established. And so in an implementation of fall tips, the process metrics are the first component. If the process is not happening, there isn't going to be any change in the outcome. So immediately implementing these regular audits. So in certain workflows, it's the champion who conducts these, and others, it's the nurse manager or the nurse educator on the unit. But the three questions that are asked are, is the patient's fall tips poster updated and hanging at the bedside? So it's got to be for the correct patient, up to date, so that the team knows that they can trust that this plan is accurate and up to date. And then the next two relate to patient engagement. And so this is the biggest change in workflow. The previous paradigm had been just doing the fall risk assessment, creating the tailored plan, and then engaging the patient and family. And so making sure to engage the patient throughout the three steps has been one of the biggest practice change and workflow changes around the fall tips protocol. So making sure to audit that process and provide just-in-time training and reminders and feedback about these engagement audits is key. So they're randomly conducted, and if the patient or family can speak to the risks and the interventions in the plan, then the patient has obviously been engaged in their plan. So the fall tips protocol has been followed. And after a period of time measuring those process metrics, you can start to look at outcome metrics like days since last fall, days since last fall related injury, falls per 1,000 patient days, and falls with injury per 1,000 patient days. And these outcome metrics can then be part of what you feed back to the unit. And so we'll talk further about the monitoring plan and thinking about who your audience is. We know from our research that nurses, staff nurses are more interested in data that they can see and is more tangible. So if you tell them that they've had 3.48 falls per 1,000 patient days and that's an improvement, it doesn't mean much. You tell them that they only had 2 patients fall this month and last month was 6, that has much more weight for a staff nurse. Whereas if you're talking to your quality improvement team, they're going to understand the fall rate as falls per 1,000 patient days. Along with these standardized definitions and metrics, you'll need an assessment for the Morse fall scale. So this is the competency component. Like Patty was saying, the face validity of the items is not as clear as it could be. So it does require training on what to assess for. And then lastly, the interventions. So there's got to be the standardized set of interventions that are linked to and tailored to the patient-specific fall risk profile. Next slide, please.
Okay, so one of the things you have to think about when you're implementing a new program is what is your communication plan going to be around it. So even a simple change in workflow is complicated in a hospital setting. So your communication plan really should target your major stakeholders. It will generate initial and ongoing support for the fall tips program and promote maintenance and spread of the positive changes that come along with it. But you need to think through, what are your goals for the communication, who will get the information, what information will you communicate, and then when and how will you communicate. So thinking through, how do you typically communicate programmatic changes at your organization, and usually multiple mechanisms is most effective. Next slide. And, as Megan mentioned, it's really important to have a way going in to evaluate and sustain the fall tips program at your site. So, you need to have a monitoring plan where you're measuring over time if the fall tips program continues to be effective. So, predefining your measures, your target ranges, where you're going to get the data, what your methods are going to be for data collection, analysis, and how you're going to use them for continuous improvement, and then identifying who is going to be responsible to make sure that these things happen. Next slide. So with fall tips, as I mentioned earlier on in the presentation, one of our goals after our initial clinical trial was to develop a tool that could be used in any organization, regardless of what electronic health record system they had in place. And so we have developed this laminated paper fall prevention poster that is 11 by 17, and we have tools associated with that poster that help organizations to implement the fall tips protocol in their hospital. So, but we know that, at a very high level, this requires organizational support. So we have to have support of the hospital and nursing leadership. We need unit director and manager support. There is the fall tips posters need to be printed and laminated. There's work that's needed around meeting with practice committee and unit nurses, making sure that we have peer champions. Megan spoke about the peer champion role, very, very important for on the ground training. We need to conduct fall risk assessment competency and training with all staff. So we have to make sure if we're basing our fall prevention plan on the risk assessment, we have to make sure that all nurses are doing that accurately. And then we need to track our progress. So, we need to look at different measures, not just as have patients fallen or have patients been injured, because those data are relatively rare, thank goodness, but, some more timely process measures. So, for example, how often is the fall tips toolkit completed? Does this happen within 24 hours of mission? Is it updated at least once a day? How accurate is the tool? So what's documented at the bedside, does that reflect what's in the plan of care? We have looked at how many days since the last fall. And so that is a reminder to staff every day about how they're doing with regard to fall prevention. And then providing continuous feedback and finding ways to do that, whether it's through email or posters, whether we're doing in-person rounding with nurses, but also looking for opportunities to promote patient education and engagement, and really reinforcing the science behind engaging patients in that three-step fall prevention process. Next slide. So just to recap, the evidence related to a fall prevention program, we know that most falls are preventable, over 90%. An evidence-based fall prevention program includes standard definitions. It includes universal fall precautions for all patients, and then the three-step fall prevention process where we conduct a fall risk assessment with the patient. We use the results of that assessment to create a tailored or personalized fall prevention plan, and then we partner with the patient and family to make sure that we consistently implement that plan. And then when patients do fall, that we have a post-fall management strategy to address issues with that patient, to revise their plan of care to make sure that they're protected, but that similar events don't occur in other patients. And then implementation of any new program, including fall tips, requires a continuous quality improvement and interdisciplinary team-based approach to be effective. So making sure that you have that in place. Next slide. So thank you very much. Megan and I are available for questions.
Yes, it looks like we have about 10 minutes, and I also want to just follow up with that. We will be holding a follow-up webinar in November. So if you are interested in implementing the evidence, we'll go into more detail about how to implement. We'll go through the train the trainer slides. So it'll essentially be a train the trainer session, and then provide more detail about implementation strategies, tools for providing feedback to staff, and some lessons learned from our pilot.
Well, thank you so much for presenting for us today on the fall tips. I would like to just take a look here in our chat, and I don't see any actual questions there. Just a real quick question for me, and this is one that I'm posed frequently within our hospitals here in Iowa, and it is the implementation of fall strategies that are individualized for someone who has mental health issues, because we are seeing more and more mental health in our hospitals. How do we move that, and how can we utilize the fall tips when we have someone with mental health who is resistive and not compliant, doesn't want to be engaged?
Right. So I think that this is a tricky population. It's a very good question. You know, I think we recently did a webinar related to this issue for the New Jersey Hospital Association. And I think our conclusion after looking at the literature in this area was that, you know, you still could use the Morse fall scale for the risk assessment, but what you really have to do is think through, are there additional interventions that are specific to the behavioral health population that you want to make sure that you include in your intervention plan? So, for example, a big factor with patients with mental health issues is they tend to be on, you know, a lot of medication. So that secondary diagnosis, you really need to think through, what are the psychiatric medications? What are the side effects? You know, are they going to have orthostatic hypotension? This is a big problem with these patients. So making sure that you have interventions in place to address that. There's other issues that are a little bit harder to address. So, for example, sometimes falls aren't necessarily unintentional in this population. So, you know, there's that component as well. But there really hasn't, unfortunately, there isn't a lot of research in this area. So this is kind of where we were with hospital-based falls 10 years ago, where, you know, you can put experts in a room and say, you know, I think this group of interventions would be effective, but there hasn't been research to demonstrate that that's true.
Yeah, and it's the same struggle, but I do think you gave us some ideas on really, you know, again, keeping it individualized and taking a look at what the diagnosis is, what those medications are, and trying to really move forward with those individualized strategies. So that's perfect. I know there's not a lot of research out there. There is a risk assessment tool. It's not coming to me what it is for the psychiatric population.
Yeah, there's
I know it's
actually
about
3 of them that are in the literature that we did look at. You know, so some of the things you have to weigh out, though, if you're going to adopt another risk assessment tool, is, you know, what else does it bring to the table that whatever one you're using doesn't? And so you should, you know, I think some of the other risk assessment tools are more complicated. I think if you're already using a risk assessment tool that's validated like the Morse, you can kind of map it to one of these other risk assessment tools to see. Probably you can do the same assessment using the Morse. You just have to look at where you would be thinking through. So, for example, the medications. We know that if under secondary diagnosis, that is where you do a full assessment of medications, and maybe you want to add additional cues to your staff around, you know, some of the more problematic medications in this population. But I think the larger issue is identifying those interventions that are going to work in your setting.
Absolutely. Thank you so much. I'm going to try to conclude so we can finish on time. We did have one comment here in the chat box. Is the TIPS toolkit posted on our Innovation website, and can it be shared? I said that we will post information on our community platform innovation site, and I think that you have already spoken to sharing that information, but if you could just reiterate one more time on the sharing of information that you started with at the beginning.
Sure, absolutely. So we are happy to spread the evidence. It's cost-free to any institution that's interested, but there are a few requirements that we ask our partnering hospitals to comply with. And so if anyone on this webinar is interested in piloting the tool, we ask that you attend the follow-up webinar so we can go through the training and make sure that we go through all the areas of risk on the Morse fault scale, the appropriate interventions, and then ways to ensure that the rollout is sustained and monitored and sustained. So we'll definitely share. We have a toolkit full of training materials and implementation protocol that we are more than happy to share, but we do want to make sure that the implementations are done with sustainment in mind.
So the process is you just email Megan, okay, and then we'll send you an email that summarizes, you know, what information we need for you, and then we provide you with the tools.
Right, and then we'll make sure to touch base on the webinar.
That sounds perfect. So I'm glad that you were able to help us out with that. And as we talk about our next fall community of practice in November, it's the 21st. It'll be a busy week for us, but I think it's going to be pretty exciting as we're able to move forward with fall tips. And again, just reiterating the required staff training, so a train the trainer kind of piece that Megan spoke to, and then potential barriers for implementation, strategies and tools for implementing and then sustaining. Is there anything else you want to add to my slide as far as just next time?
No, I think you've covered it. Thank you.
Mm-hmm. And I want to just point out, we do have our October HIIN education calendar. It is on our Innovation platform. And a big shout out to Stacy Klinker, who's our program manager now. And she basically has linked registration. So when you register here, there's a link. It'll help really simplify our process for our HIIN hospitals to get more and more education. And then I do want to just remind you about our upcoming event. The Iowa Healthcare Collaborative's 14th Annual Conference is November 8th. It is at Prairie Meadows in Altoona, and you can register online at our website. This is me. I want to thank you so much for joining us today. And please feel free to reach out to me with any fall prevention questions or requests that you might have. And as you already know, you can reach out to your assigned improvement advisor at any time to get assistance. And thanks for joining us today again as we work together to improve patient safety. I really do appreciate your time. Thanks so much.
Thank you. Bye.